So today we will now move up in the ladder, let's say from the cell level, we will go now to the organism level, to the human level. And we will talk about deterministic and stochastic effects of radiation in humans. So let's start with the deterministic effects. Deterministic effects is maybe an old terminology, but I think it's so much used that it's important that you get familiar with that. Years ago, they were even called non-stochastic effects, and they were assumed to have a threshold. So a little bit like in toxicology, you know, there is no effect if the dose is less than a threshold, and there is 100% the probability of having the effect if the dose is greater than the threshold. In reality, deterministic effects can be early and late, so there's not necessarily early, and they are also probabilistic in the sense that the risk, as everything in nature, is always is never zero and is never 100%, and is dependent on the dose and on the dose rate. A better definition of deterministic effect, so is more about the mechanism. So stochastic effects are essentially linked to heritable mutations. Deterministic effects are really linked to cell killing. So in stochastic effects are generally linked to non-lethal lesions that somehow change the DNA. There's a genetic or epigenetic mutations, if you want, while deterministic effects are really linked to the killing of the cells in a tissue. In fact, let's say, generally speaking, a deterministic effect will occur when so many cells are killed that the body cannot replace them within a reasonable time, usually because the stem cell pool has also been severely depleted. The relevant tissues and organs fail to function properly, and health consequences ensue. So how do we describe the deterministic effects? Generally, the queen function which is used for describing the deterministic effect is always a sigmoid. There are different types of sigmoid, one which is very much used mostly in radiation protection, really, not so much in radiation therapy. Radiation protection is the Weibull function. So the Weibull function gives you the risk of deterministic effect, and is 1 minus the exponential of minus logarithm of 2 d divided by d50 to v. So v gives you the how steep is the curve. So essentially, if you have a high inter-individual variability, you will have a very shallow curve. If you have a small inter-individual variability, you will have a very steep curve, you know, going almost from 0 to 100, almost like in the non-stochastic case. D50 tells you what is the range spanned on the dose scale. When D is equal to D50, if you put D equal to D50 in the formula, you find that R is 1/2, and this is why D is called D50 as this name, D50%. As I told you in the previous slide, the deterministic effects are dose rate dependent. Generally, in this formula, the dose rate dependence is simply represented here. So the D50 is in the D50, is included in the D50. So the dependence of D50 from the dose rate, the D over the T or D point, is given by D infinite plus D1 divided by D point. So if D point goes to infinite, very high dose rate, D50 is simply D infinite. Otherwise, you will have to apply a correction factor. But you see that you need two parameters here. You need, of course, you know the dose rate, but you have two more. D50 is only one parameter, but now you need two parameters, D infinite and D1. That gives you the dose rate dependence of D50. Now, the sensitivity of the different tissues is very different. So there are some tissues that are very sensitive to deterministic effects, and other tissues that are much more resistant. This gives you the approximately tolerance dose. The tolerance dose is something that comes from the radiotherapy environment, the tolerance dose is generally defined as the dose corresponding to a 5% probability of deterministic effects. And generally, radiotherapy is done in a way that you want to limit the tolerance dose to 5%, the probability of side effects, the normal tissue complication probability, NTCP, we will see it later, to 5%. But you see that depends very much on the tissue. If you take the testis or the lens or the ovary, these are extremely sensitive. The tolerance dose is quite low. But then if you move to, you see, to kidney, heart is here, stomach, spinal cord, brain, small intestine, urinary bladder, and adult bone, these are much more radioresistant. You see it also here. It's a color scale. You see when you have red is so going, let's say, from the lower part, these are particularly resistant, and then when you move to the red, you go into sensitive organs. And now this is how it looks like if you take D50 and V, the impact of D50 and V. So these are three different endpoints for whole body exposure. This is the GI syndrome, so the gastrointestinal syndrome, which is a lethal syndrome. So this is the probability of dying by gastrointestinal syndrome. And you see that the D50 is approximately 15 gray, and the curve is relatively shallow. You see, it's quite shallow. While you see for vomiting or fibrosis, fibrosis is for irradiation of the chest or whole body, and vomiting is really for irradiation of the abdomen. Of course, you have to irradiate the stomach. The D50 is smaller, and the curves are more steep. They are not so shallow. A collection of parameters I will show you is in this slide here. We will go here in a second. I just wanted to give you a simplified image here, where you have early morbidity and late morbidity. So, as I told you before, deterministic effects are not only early effects, can also be late effects. Generally, late effects are defined as those effects that occur more than 6 months from exposure. And you see that for the skin, you can have early morbidity, erythema, moist desquamation, ulceration if you have a very high dose, and late morbidity, atrophy, hair loss, telangiectasia. This applies essentially, you see, for all organs. You see, if you take the lung, you can have cough as early morbidity, but the late morbidity is quite severe because you can have fibrosis and you can have pneumonitis induced by radiation. Also for the lower gastrointestinal tract, let's say for the colon, you will have diarrhea or fatal gastrointestinal syndrome, which is quite fast at very high dose. Of course, you need 15 gray. But in late morbidity, you can have bleeding and necrosis and perforation fistula, and so on and so forth. You can look at all the different endpoints. Please note that in terms of lethal endpoints, there are 3 lethal endpoints. One is the hematopoietic syndrome, where the dose, the D50 is approximately 3 gray. In reality, I told you since the beginning, is more like 4 or 6 gray, the D50, considering medical attention. Then there is the gastrointestinal syndrome, where the dose, the fatal is 15 gray. And then the CNS syndrome, where the D50 is 60 gray. So clearly, if you have whole body exposure, the fatal hematopoietic syndrome is the one that occurs at the lowest dose. But if you have a very high dose, like 100 gray or 70 gray, 80 gray, you die first, because the hematopoietic syndrome takes many weeks, because you have to deplete the bone marrow of the stem cells, and then you cannot produce any more red blood cells, and then eventually you die. But the fatal CNS syndrome is a matter of only minutes, very high dose, but the death occurs because essentially you lose the whole control of the body. It's like shooting in the head, if you want. It's like destroying your brain. So clearly it's much faster, but of course at a much higher dose. These are instead some values. You see, this is the D50, this is called theta in this particular paper, but it's the same, D50, D infinite, and D1. These are the two parameters that you need to calculate the D50. This is dose rate dependent, and this is not dose rate dependent, is the one that you have a high dose rate. The shape factor, the V, and then this is the RBE. The RBE is now calculated. This is related to alpha particles when it is known, of course, and this tells you what is okay, you know the definition of RB. The problem is that the definition of RB is strongly related to the level of the effect, okay? In this specific case, these are average RB because we don't have much information, of course. We don't have much information. It's a sort of average RB on different levels of effect. The threshold dose here, there is no threshold dose. We have to agree on this, of course, but you can define a sort of quasi-threshold dose, where essentially you define it based on the 1% level of effect. You say, okay, if it is below 1%, I assume that there is no effect. So you see there are many, the mortality I told you before, the gastrointestinal syndrome, external and internal. You can also have it by internal exposure, then you need a higher dose in the colon. You see the threshold dose is like 10 gray here, but if you go to the bone marrow syndrome, the threshold dose without medical care, the threshold dose is only 1.5 gray, and the D50 is approximately 3 gray, with a D1 factor of 0.07 that modulates for the dose rate. If you have medical care, it goes up to 4.5 gray, 0.1 gray square per hour is the dose rate correction factor, and 2.2 is the threshold dose. If you look at the other lethal syndrome, I think is not here. Yeah, the CNS. The CNS syndrome is not here. There is the embryonic fetal death. Okay, this one is much lower. You see the dose for embryonic fetal death, depending on the gestation day. If you go to the initial embryo, the D50 is about 1 gray, which means that the threshold dose is only 0.1 gray. So even a relatively low dose can be fatal for the embryo, especially in the first 2 weeks. First 2 weeks really is a high probability of death. These are all data from Hiroshima and Nagasaki. We will see them later. You see, in the mortality syndromes here, they also included pneumonitis here, because of course pneumonitis can be lethal, as we all know now from COVID-19. The D50 is 10 gray, and the threshold is 5.5 gray. So we have to be careful, of course, we want to use low-dose radiation to treat pneumonitis as anti-inflammatory agent, but we have to be careful because with a 5 gray threshold, you start to induce pneumonitis. Of course, they want to use much lower dose, like 1 gray or 0.5 gray. And this is for morbidity. You see, these are the different parameters for morbidity, including prodromal syndrome, which is vomiting and diarrhea, which is one of the first effects, of course, very early, is one of the first effects of radiation, you see. And the D50 is about 2 gray and 3 gray, but you see the threshold dose is about half gray. So from half a gray on, you have probability of having diarrhea and vomiting if you are exposed in the abdomen. Lung fibrosis, which is one of the main limits for radiotherapy of the lung cancer. Skin burns, hypothyroidism, thyroiditis, cataracts. Cataracts that was supposed to be for many years was assumed to be totally non-stochastic, so that there was a threshold, but actually there's not a threshold. The D50 is 3, but the shape factor is relatively low. I mean, there is some variability, but you see the threshold dose is about 1.3 gray, but which was generally assumed, you know, that there is no cataract if you're exposed below 1 gray. This is almost true, but not quite true, you know, because 1% in Chernobyl, where you had exposure of thousands of people to doses below 1 gray, you saw a lot of cataracts, of course, because 1% if you expose thousands of people, you have 10, 20 cases of cataracts easily. Severe mental retardation, you see, is the one with the lowest dose threshold here. Threshold, again, defined as 1%. If you compare, the only one with the same low threshold is the fetal death. So you see that in the exposure between 8 and 15 weeks, so when this is non-lethal, because it's quite advanced, but between 8 and 15 weeks, you can have severe mental retardation with the D50 of about 1 gray and a threshold dose of about 0.1 gray. So now I'm sorry for these graphic images, but you have to know what I'm talking about. You know, you can check all the different diseases, but these are among the most common. This is mucositis, so the inflammation of the mucosa. This is a typical deterministic effect in head and neck cancer treatment. It's one of the showstoppers. I said the reason why you have to reduce the dose in the head and neck is that you have mucositis, which is very, very annoying. Non-trace cataract, this is how it looks like. A non-trace cataract is one of the cataract types induced by radiation. Skin erythema is the most common side effect in radiotherapy. You see it here. It's not very severe, but you see this is a head and neck treatment with a clear skin erythema. The worst case instead is ulceration of the skin, which occurs at much higher dose. This then does not occur in radiotherapy. Of course, you are careful in radiotherapy not to have. In fact, this hand comes from Hiroshima and Nagasaki. It was a person exposed only the arm at a very high dose. And pneumonitis. Pneumonitis, as I said, is an effect that can be induced by radiation. You see it here. This is interesting because this was for the treatment of a Hodgkin's lymphoma. And the field, the radiation field is shown here. It's a square. It is an old slide, as you can imagine. So the field was done with the shield, with the block. This was the field, and now look at the shape of pneumonitis here. This is the inflammation of the lung and pneumonitis. You see that really matches the radiation field. So this is obviously radiation-induced pneumonitis. Now, I told you that we can define an RBE. And I also told you that, of course, the problem is that the RBE is always dependent on the level where you define the RBE. So if you take the RBE for a mortality syndrome, you know, like hematopoietic syndrome or gastrointestinal syndrome, then you have to decide if you want to go to 10% survival, to 1% survival, and so on and so forth. And as you know, the RBE changes. Now, the definition of RBE is quite complicated in radiation protection because it depends on which effect you are looking at and which doses you're looking at. If you remember, in the first lectures, we introduced the concept of sievert. Sievert, which is defined somehow as the product of the dose in gray, the physical dose in gray, times a weighting factor. But the sievert is really only defined at very low dose. When you talk about deterministic effects, where you generally look at higher doses and sometimes high dose rates, you know, the sievert is defined at low dose and low dose rate. You use the DDREF is used to calculate the sievert. But when you go to high dose and high dose rate, how can you define which is the unit that you use? Well, not the sievert, of course. Generally for radiation protection purpose, but we will see not really for radiotherapy, but for radiation protection purpose, you can still use the so-called gray equivalent, where the gray equivalent is defined as gray times RBE. Now, in radiation therapy, they have finally decided to use simply the gray, but writing RBE weighted dose. So the RBE weighted dose is still given in gray, not in gray equivalent, which is going to cause a lot of confusion. This is a recent suggestion of ICRU. But anyway, the RBE, what is the RBE for radiation protection purposes? The RBE you see is recommended here from the ICRP, from the International Commission on Radiological Protection. The RBE for protons is about 1.5. For neutrons, depends on the energy between 6 and 3. These are fission spectrum neutrons, and these are fast neutrons. Of course, it's lower for fast neutrons. And for densely ionizing charged particles, alpha particles and heavy ions, it is recommended 2.5 with a range between 1 and 4. Now, when are important deterministic effects? Well, the scenarios where they are important are, of course, radiotherapy. Radiotherapy, this is extremely important because determines the tolerance dose, and the tolerance dose then tells you how much dose you can give to the tumor. So that's why you cannot give to the tumor a dose which is so high that you are 100% sure that you will sterilize the tumor, because you will have too strong morbidity. But then, of course, you can have deterministic effect in nuclear accidents. This is very common. We saw something also when we looked at biodosimetry. Ultra-terrorism, this we will see in the next lectures, and space travel. These 2 points will be touched in the final lecture of the course. In radiotherapy, as I told you, what you really want to do, this is the dose to the tumor. And you want to compare the probability of controlling the tumor control probability of TCP, and the probability of complications, severe complications. Generally, they look at late effects, because late effects are more difficult to treat than early effects. This is called NTCP, normal tissue complication probability. So the idea is that you see the TCP curve must be here, and and the NTCP curve must be to the right, because of course this defines the therapeutic window. At this dose, for example, you have a 90% probability of TCP and about a 5% probability of NTCP. If you use one technique like particle therapy, for example, if you use an old technique like 3D CRT, the curve of NTCP shifts to the left. And now you see for this dose, the probability of side effects is too high. So you should go down to this dose to have a low probability of side effects. But at this dose, the TCP is too low. You see, it's only 40%. So you see that radiotherapy is not about killing the tumor. Radiotherapy is about sparing the normal tissue. That's the real trick. Because if you can spare the normal tissue, the NTCP curve moves to the right, to the right, to the right, and then you can be sure that you will kill the tumor. The NTCP model, you see, is what is actually used in radiotherapy a lot to predict. And you see, these are examples. For example, this is the risk of radiation-induced liver disease, which is the limiting factor in the treatment of hepatocellular carcinoma. This is the mean liver dose, and this is the NTCP model. So you see, it is a good model. And of course, you see the data points never go up here, because there is never in radiotherapy the case where you have 100% of your patients with the radiation-induced liver disease. This means that your radiotherapy is terrible. You will stop it immediately. But you see, in this model, you have some cases, these are all different radiotherapy cohorts. In this case, the radiotherapists were a bit aggressive. They went up to a mean dose of more than 40 gray, and sure enough, they found that 30% of radiation-induced liver disease that they don't want. They should go down to 5%, so they should be down here. So this is very important, you see. It's extremely important, because that's what you need to know to do radiotherapy. It's particularly complicated, though. We will not go into details in this course. We will go into details in the medical physics course. Because the problem is that in radiotherapy, you don't have whole body radiation by definition. You have only partial body radiation. So even for the liver, you don't irradiate the whole liver. So the mean liver dose means that you average a volume of the liver which receive a very high dose with a volume of the liver that receive a very low dose. I will not go into details again, I tell you here, but I just want to tell you that generally the model which is used in the in radiotherapy comes from the so-called Lyman model. In Lyman model, we only do here the case of uniform irradiation of a fraction V of the organ at a dose V. It's an easy case, you know, where you have only a fraction of the organ is irradiated, the fraction is V, and the dose is D. Of course, in reality, it's much more complicated, but this is a good start to give you an idea. Then in this case, the NTCP is calculated not using the Weibull formula, but similarly, let's say, using the integral, the cumulative integral of the Gaussian distribution. So you do 1 over square root of 2 pi is a normalization factor, integral between -∞ and t of e to minus x squared halves, where t is given by d minus d50 divided by m times d50, and d50, which is a function of the volume, of course, you see d50v is given by the d50 for the whole organ times v2 minus n, and m is another correction factor which is used here. So this is the Lyman model, and this is an example of Lyman model actually applied. This is a real case, applies to the late rectal bleeding. This is actually, you see, is a little bit more complicated because this is not the constant dose, it's an equivalent uniform dose, but we will not go into this detail. That's only to show you that it's fairly well representing the observed toxicity in terms of rectal bleeding with these parameters. Of course, these parameters have to be defined somehow, you know. So you have to define N, M, and the TD50. So the D50 in the formula that I showed you. In this case, you have N 0.23, M 0.19, and TD50 18.9 gray. And then you can describe the toxicity, you know, for the rectal bleeding. Okay, this is all for the deterministic effects for now. We will come back to it in the radiotherapy lecture, but let's now move to the stochastic effects. Now, stochastic effects are, by definition, as I told you before, they are late radiation effects that occur with some dose-related probability. Generally, they are divided into three categories. Teratogenic effects, so those on developing embryo and fetus. Somatic effects, so in your own organism, but late. And hereditary effects that occur in the progeny. To give you a clear, we will spend most of our time on somatic effects, so on carcinogenesis. This is by far the most important stochastic effect. But to give you an idea, just a rough order of magnitude for your memory, if teratogenic effects occur with the probability of 1, somatic effects are 1 over 10. So they are much more unlikely than teratogenic effect. We saw this already in deterministic effects, you remember, but this is also true for stochastic effects. And hereditary effects are 10 times lower than somatic effects. So somatic effects are 10 times lower than teratogenic effects, and hereditary effects are about 10 times lower than somatic effects. So imagine 10%, 1%. Teratogenic, somatic, hereditary effects. However, we will focus on somatic in this lecture because, of course, teratogenic effects are very rare. So you have teratogenic effects only if you irradiate the embryo and fetus, and you generally don't do it by definition. I mean, even X-ray that is only milligray, you don't give X-ray to pregnant women unless it is strictly necessary, you know, because there is some terrible fracture, you know, there is something which is life-threatening for the fetus or for the mother, but generally you try not to do it. So the carcinogenic effects of radiation were clear very early, you know, that actually Marie Curie died, she was exposed with enormous doses. She didn't really die of cancer, she died of a form of anemia because of the very high dose that she was exposed to. But we know that there is that radiation-induced cancer essentially from 3 sources of information: animal experiments, human cohorts, epidemiology, and mechanistic information from the mechanisms. The animal data are very useful to study, and we saw already something in radiation carcinogenesis study. Here we will focus on the epidemiology for the relative patterns, but of course they don't give you the absolute risk. You need epidemiology for that. There is no much alternative, but there is also a lot of uncertainty in estimating cancer risk. This should be clear from now. We have a very, very large uncertainty due to all these different factors. You know, when you have epidemiology, you need to do dose reconstruction, and you need to have a lot of cases to have a good statistics. You need to have a lot of controls that are real controls. You have to take into account the latency time from exposure to expression of cancer. Dose extrapolation, if it is in a different dose range, dose rate extrapolation, which is one of the most uncertain factor. You remember the DDREF. Age and time dependent, also very critical. Transfer models, we will see. I mean, one thing is to have a risk in Japanese population, another thing is to transfer it to a European population. And the problem of contamination with neutrons, for example, which is a big problem in Hiroshima and also in Nagasaki. In any case, most of our info, this is my message, I mean, almost everything we know about radiation carcinogenesis, really almost everything we know, comes from the survivors of Hiroshima and Nagasaki. We will describe the explosion of the bomb quite in detail in the nuclear weapons and ultra-terrorism lecture. But of course, you know that in 1945, 2 atomic bombs were dropped, one in Hiroshima and 2 days later in Nagasaki, in Japan. They caused some, we will see, some 300,000 casualties. And then the survivors were exposed to radiation at different doses and simultaneously, depending mostly on the distance from the hypocenter. So from the epidemiological point of view, this is an ideal situation because you have the same population exposed to different doses as a function of the distance. So if you can reconstruct the dose, which was not easy, but the Japanese did it brilliantly, you can actually have, let's say, the controls are internal at the population. I become a control if I am far enough that my dose is extremely low. This has been done in the Radiation Effects Research Foundation in Japan that started to work in 1950 and is still extremely active, both on survivors and on F1, on the first generation, and even in F2 now. They're also working on the second generation. And this is the website that you are more than welcome to visit. I mean, it's very interesting, I have to say. So what is the cohort here? The study was called the Lifespan Study, started in 1950, I told you. And the whole population was about 120, was exactly 321 survivors. However, out of these 325 survivors, only 80,205 really entered in the study because they have individual dose estimates. However, some of the controls are here with 0 because some of the controls were completely out of city. They were like in Tokyo to do some business. So they were counted because they were actually resident in Hiroshima and Nagasaki. So there is no major difference in the control, but they were exposed to a 0 dose. So out of these 80,000 people that were with individual dose estimates, 62.3%, no, sorry, not out of this one in total, 62.3% of this population died between 1950, when the RRF started, and 2009, which is the last analysis in Report 14 published in 2017. So this is amazing if you think about the bomb was 1945. So it is something like 60 plus 15. So it's 75 years ago. So the bomb was dropped 75 years ago, but there are still a lot of survivors. You know, not I mean less than 50%, but more than 30% are still alive. That's because these are mostly people that were exposed when they were very young. And the average lifespan of the Japanese population is quite long. So there's still a lot of people surviving. So out of the people that died, 24,448 solid cancer deaths were observed. And out of this, it has been estimated, this is true, all of this is true, it's just numbers. This is an estimate, the estimate making by comparing the population of exposed to the population of non-exposed, or at zero dose or at negligible dose. So for example, people that went outside, people that was even with individual dose estimate, but like less than 1 milligray, then you put it in the control. So you have 992 cases attributed to radiation. This makes some 4% of the cancers. This is extremely important. I mean, when you watch TV and you see the documentary on Hiroshima and Nagasaki, they are greatly misleading. They say something like 300 people were killed and many more died later. Yes, of course, many more died later because we all die. But in reality, if you take Hiroshima and Nagasaki, the excess number of cases is amazingly low. It's only 992. It's not millions, like sometimes you read in the newspapers. It's less than 1,000. Still, this is by far the largest cohort in epidemiology for cancers induced by radiation. More recently, really in the past 10, 15 years, it has been clarified, it has been seen also an excess in death which are not cancer. This is mostly cardiovascular disease and a little bit of other kind of disease, non-cancer disease. And this makes actually approximately 1% of non-cancer deaths seems to be radiation induced. We will also see this today. So the reconstruction of the dose, as I said, was particularly complicated, but was done brilliantly. I like this plot. This plot shows, this is Hiroshima. 0, 0 is the hypocenter, and this is, you see the map in terms of distance from the hypocenter in kilometers. And the color scale gives you the position, every dot in this map indicates a single survivor, It's really amazing, you see. So when you see the yellow dots here are doses greater than 1 sievert. Then the red, if you go far from the hypocenter, the dose goes down. We will see this when we will see the atomic bomb, but you can already expect, that the decrease is essentially exponential. These are mostly gamma rays. There is a little component of neutrons, but these are mostly gamma rays. So we have seen in the physics that the intensity goes down with the exponential. So if you go away from the center, you see that the red is more than, the yellow is more than 1 sievert, the red is 0.51 sievert, and so on, until this gray region here is less than 5 millisievert. So this is a sort of internal control, if you want. These are people that received very, very low dose at the explosion. So every one of these dots is one survivor. And how do you plot these results? These are not the most updated plot, but give you an idea. Generally, you plot the excess relative risk, or ERR, as a function of the dose. What is the ERR? Well, you see it here. If E is the observed number of cases in the test population, so for example, number of cancers among the survivors, and C is the observed cases in the control population, for example, people that were outside or people that received 0 dose or a negligible dose, then the ratio E divided by C is called relative risk. And excess relative risk is simply E minus C divided by C, so it's RR minus 1. It's also important to define the excess absolute risk, which is the product of ERR times the control in percent, because this gives you the risk, the real risk of mortality. Depends on what is the background level. You have to multiply the relative risk times the control risk, which is, make no mistake, leukemia. Here is the curve of leukemia. So if you look at the ERR for leukemia, it's extremely high in comparison to solid cancers. You see, so the scale here goes from 0. The excess relative risk, the relative risk goes to 1. You know, if the test population is the same as the control, the excess relative risk should go to 0. Even though, you know, sometimes looks like it goes below 0, which is what I told you in the carcinogenesis lecture is called the hormesis. But this is very controversial, I told you. You see, for leukemia, it looks like the relative risk is much higher than solid tumor mortality, but in reality, in terms of absolute risk, leukemia is very low as compared to solid tumor mortality, because of course, the background of leukemia is much, much lower than the background of tumor mortality, solid tumor mortality, which is dominated, as you know, by lung, breast, prostate, colon, you know, all solid tumors, not liquid tumors. Also, leukemia is very special, you see, because the dose response curve for leukemia since the beginning looked like linear quadratic, not really linear, which again, if you think to the Philadelphia chromosome, makes sense. This is a tumor strongly related to chromosomal aberration. The dose used here is a dose to the bone marrow, is calculated as dose to the bone marrow, while for solid tumor, it was decided to use the colon dose, because the colon dose is sort of average of the dose to the internal organs. And in what you see here is this line gives you it connects the points. The band gives you the confidence interval, and the line gives you the best fit. Then I will show you some more data in the coming slides. Also, there is a big difference in leukemia and solid cancer. It comes from the latency time. The latency time for leukemia was extremely short. You see, when the life science, the lifespan study, LSS, in Hiroshima started, they immediately found a large excess of cases of leukemia, even though you see cases per year 10. So we're still talking about low numbers, but much, much higher than in the control. Then the difference between spontaneous cases that of course increase with age, and radiation-induced cases, if you want. You know, the red gives you the difference, the points are the real points. The red gives you the estimate of the excess cases due to radiation, becomes smaller and smaller. While for solid cancer, at the beginning, there was nothing. So there was no difference compared to the controls. But then you see, starting some 10, 15 years after the exposure, and certainly 20 years after the exposure, you start to see an increase. And you see that, of course, the absolute case per year are much higher here for solid cancer as compared to the leukemia, even though the difference between attributed to radiation and spontaneous is much smaller. So the relative risk is much smaller, but the absolute risk is much higher. The other point, which is a large uncertainty, is the age and gender dependence. So this is actually for solid tumors. This is the age at time of exposure, and the risk, this is the attributable lifetime risk, so it's the absolute risk per sievert, so per unit dose. And you see that it goes down with age, it goes down. So the young population is substantially more sensitive than the old population. And moreover, males and females are not quite the same. You see that females tend to be more sensitive, especially in young age. That's mostly because of the breast. They tend to be more sensitive, especially in young age, than males. So overall, females are here and males are here. In Hiroshima and Nagasaki, they generally use this function to give the ERR as a function per sievert, because of course, for solid tumors, as I told you before, the dose response curve is linear, so you can do it per sievert, per unit dose. And they use sievert and not gray because, as I told you, there is a neutron contamination, so you weight the neutron dose to have a sievert. And they generally use an exponential function. So ERR 30 at 30 years old here, exponential minus K A minus 30, where A is the age at exposure. So this is described as an exponential using this form. So if you find in a table the excess relative risk at 30 years, you can calculate the excess relative risk at any age using this formula. And these are examples of excess relative risk per sievert. Again, all of them calculated at 30 years. Then you can correct them for the age. This is not the most recent data, but I think they are good enough to show you the main point. You see that for leukemia, for leukemia, you see the excess relative risk for sievert, this is male and females, is about 2, extremely high, but the background is very low. So here you have some 1.5%, which is much lower than the total solid, which is between 10 and 14%, depending if it is male or females. And then you have it for many, many other organs. You see, you can look at the sensitivity of the different organs, and eventually you come out with the sum. The total excess relative risk for males is 0.38, for females is 0.77. In the Japanese population, the background is 28% for males and 20% for women, at that time at least, which result in 10% lifetime excess risk per sievert and 14% lifetime excess risk for females. This is actually the same, but is now a more recent data. This is from the report 14 in 2012. And you see here, these are now given here. This is interesting. You see here the points. This is the ERR per gray here is given per gray, but same as per sievert before. And the sides of the black block give you the number of cases, I mean, how many cases you have. And of course, you can also see this from the sides of the 95% confidence interval, which is given here. You see that, of course, it's much broader when you have small points. So you can see in some cases, you see the ERR goes to the right to high values, like for, again, for this is for lymphoma. I think leukemia is not included here, but you have also non-neoplastic disease, like blood disease, like anemia, and of course, what is particularly important is the respiratory disease, digestive disease, infectious disease, other disease, and so on. Circulatory disease are particularly critical because here the background mortality is extremely high. We will go back to this one. And here you can see the different cancers, you know, the sensitivity of the different cancers, they are fairly different. If you put them all together and you plot them as a function of the weighted column dose in gray, so this is weighted as a column dose, these are the points. So you see it's very difficult to see what is happening at very low dose here. You have error bars are very big. It's true that some points seem to go down, but in reality, this is the situation. This is the high dose region. Of course, nobody's exposed in Hiroshima and Nagasaki to a dose higher than about 3 sievert, because then it will be killed, not necessarily by radiation, but will be killed by, it would be too close to the hypocenter, will be killed by, as we will see, by the blast wave or by the thermal wave. And you see that these are different types of fits. You see, this is a linear quadratic model, a linear quadratic model only for the dose below 2 gray, so excluding these points, and this is the linear model. Statistically, there is no way that we can prefer the linear quadratic model to the linear model at the moment. So statistically, considering the uncertainty, we have no evidence that the curve is linear quadratic. We can stay with the linear model. But you see, could be linear quadratic, we just don't see it. It's a small curvature, of course, but unless you fit them below 2 gray, then, but you see, these points will not fit. But you remember when we saw the modeling of carcinogenesis at these doses, radiotherapy data show that the curve starts to saturate because of the repopulation effects. Now, the problem is that we have the coefficients of risk from the Japanese population, but can we transfer this coefficient of risk to the world population? We have a problem here. The problem is that the background that you use directly, actually, to calculate the excess absolute risk from the excess relative risk is substantially different in different countries. This is an example. These are different cancers. This is the number that the International Association for Cancer Research gives to the codes of the different tumors. And this is now the incidence. These are incidence, not mortality. These are incidence rates per 100,000, so per 10 to minus 5, for males and females in Japan. In the United States, this is the SCER, is a large epidemiological study in the United States. In Colombia, in the Cali area, and in Sweden. Now, if you look, these are all solid cancers. Now, if you take all solid cancers, you already see quite a significant difference. You see, if you take males, in United States is like 335, and in Colombia is only 173. So even for all solid cancer, the background in Colombia is 50% than the background in United States. And then in some cancers, you see the Japanese population, of course, is particularly important because of because all the data in Hiroshima and Nagasaki are for the Japanese population. But you see the stomach cancer, where you have seen a lot of statistics of stomach cancer, but you see the background of stomach cancer in Japan for males is 61, in United States is 7. So stomach cancer is relatively rare in United States, while it's very common in Japan. And the same for liver. You see, liver is relatively common here, but relatively rare in United States. While if you take breast cancer, for example, breast cancer is much higher in United States than in Japan, even though in Colombia is more similar to Japan than to United States. And if you take prostate, you see prostate is 14, of course only for male, 14 in Japan, 112 in United States, where there is also strong influence of the African American population, where the risk of prostate cancer is much higher than for the Caucasian population in the United States. So you are now with the big problem, because now you have the risks from Japan, and you want to get the risks in United States or in Europe, whatever. How do you manage that? Of course, one simple way will be simply to multiply the risk times the new background here. But how do you know that the risk is not affected by the background itself? So this is, of course, a big problem. I will not go into details here. There are different ways to approach, but the transfer of populations is a big problem. And the other big problem, of course, is to finally decide on the shape of the dose response curve, because we see Hiroshima and Nagasaki is compatible with linear behavior. But in reality, what happens at low dose is not clear, because essentially everything can happen here. You can have linear quadratic, you can have bystander effect that will increase the low dose sensitivity here, or you can have adaptive response hormesis that will give you a threshold or even a negative bump here. We know for sure that in the region, let's say 0.05 sievert, previously was 100 millisievert, now it's like something like 50 millisievert, up to 2.5 sievert we have seen, where Hiroshima and Nagasaki is the maximum dose. This is linear, that's for sure. But what happens at high doses, again, which is interesting for radiotherapy, is also unclear, because of course you expect that we have seen in the Hodgkin's lymphoma case, there was a saturation, but in principle there can also be a decrease or simply a linear increase. So epidemiology also helps us here, the gold standards, which is A-bomb survivors. Of course, we can get a lot of information from radiotherapy, from second malignancies in radiotherapy. But you have to be careful here. You have to be careful because radiotherapy is characterized by very high dose in the tumor region and low dose surrounding. a good sample comes from the pediatric cancers, you know, because they of course, most pediatric cancers, fortunately, are non-lethal. 80% of pediatric cancer patients survive more than 5 years, but 20% of them develop second malignant neoplasm, SMN, in 30 years. These have different causes, of course. This can be continuing lifestyle, genetic predisposition, especially for the pediatric tumors. Genetic predisposition is very important, but also the treatment of the primary cancer, you see. And this is clear in some cases, like in the CCS study, which is done in St. Jude. St. Jude is the main pediatric hospital in the world, so they have a very large statistics. They worked on 14,000 survivors of childhood cancer. These are some data. Where you see a relationship of this is the relative risk now, you know what this is, for the central nervous system, secondary cancer, okay? Meningioma, which is a benign tumor, and glioma, as a function of the dose. So you clearly see a tendency to increase. And even for thyroid cancer, you seem to have an increase in this region and then a decrease. Another cohort, not radiotherapy, but radiodiagnostics, comes from the CT scans. Now, CT scans are a relatively low dose, but you are in the order of the millisievert. So if you apply Hiroshima and Nagasaki, you calculate the dose, you know, and you use the ERR from Hiroshima and Nagasaki, you can estimate something like one cancer every 1,000 head scans in child less than 5 years, because, you know, these are much more radiosensitive. 1 in 2,000 for adolescents, let's say teenagers, and 1 in 500 if you take abdominal or pelvic scans, regardless of age. That's a lot. That's a lot. That's really a lot. This comes from atomic bomb survivors. This was a paper on New England Journal of Medicine coming from David Brenner and Eric Cole. Eric Cole is the author of the book that I recommended from Columbia University, and caused great discussion in the community, because of course the medical doctors said, oh, well, I mean, these are only theoretical and we need the CT scans, because of course the CT scans are very, very useful for curing people, for diagnosis. So, but later, based on these predictions on Hiroshima and Nagasaki, there was an epidemiological study. This was published in Lancet on June 7, 2012. And this was done in UK, and the results were very supportive of the Hiroshima and Nagasaki study. You see, there was 176,000 children and adolescents in UK, less than 22 years old. CT scans between 1985 and 2008, and you see here the relative risk for this is the relative risk for leukemia as a function of the bone marrow dose. You see the increase, the clear increase, linear, and this is the relative risk of CNS malignancy as a function of the brain dose. You see the doses are of course fairly high. You go up to, here you go to 50 milligray, and here you go to 350 milligray here. Of course, you have to see where is the threshold, but a CT scan generally is no more than 1 milligray. So the conclusion is that 2-3 head scans triple the risk of brain cancer, and 5 to 10 head scans can triple the risk of leukemia. This is published in Lancet. So, but you know, you always have to be careful, even when papers are published in these spectacular journals. I mean, a few years later, there was this other paper. Can't remember the, oh, this is 2000, and I cannot read the year. It should be up here. Okay, we will, oh, okay. It is, let me see the year. Because the Lancet paper was in 2012, this paper was 2015, so 3 years later. There was a French study, and the French study also took a cohort children with CT scans, and they looked at the excess relative risk for CNS, brain tumors, leukemia, and lymphoma. This is the excess relative risk. This is the 95% confidence interval. So it's interesting. You see, they also found quite substantial ERR greater than 0. You see, for even though it's barely significant, at least a 95% confidence interval, you go includes the 0 in all cases. But looks like 0.022 for CNS, 0.057 for leukemia, 0.018 for lymphoma. But if you adjust for specific cancer predisposition factors, so if you look at the patients and you say, but what were the predisposing factors included? Like this kind of, there are different, including ataxia telangiectasia, you know, and other factors included, you see that the excess relative risk then decreased significantly. So is this a bias or is an increase of sensitivity? So this is still an open discussion. I mean, it can be a bias in the sense of say, okay, you see an effect. These numbers are now essentially all of them are non-statistically significant. So you can have a bias because you say, okay, of course you see an effect because we do CT scans mostly in children that are predisposed for cancer. And that's why eventually they get cancer, not because of the CT scan, but because we have a prevalence of CT scans in those children that are predisposition for cancer. So here the discussion is still open, but I think it's extremely important to clarify this point. So at the end of the game, what is the ICRP? How do we use these numbers from Hiroshima and Nagasaki? We have seen that the number, the magic number from the excess relative risk per sievert in Hiroshima and Nagasaki is about 10%. Now, for the working population, this is generally lower because you take the working population, you exclude the children and the teenagers, so it's a little bit lower, 8%. But then you have the problem of the low dose rate exposure. So if you want to apply Hiroshima and Nagasaki to me, you cannot use the high dose rate because Hiroshima and Nagasaki, the whole exposure was in 1 minute, but here in our case is in years. So as I told you already in the previous lecture, the ICRP applies a DDRF of 2. So the 10% abruptly becomes 5%. And this is 4% for the working population, but this 5% is a sort of magic number. I mean, the 5% per sievert is what people generally use to estimate the risk of late morbidity. They use 5% per sievert. So if you have 1 sievert, your probability of cancer will increase 5%. Keep in mind that now the probability, the background in Germany of cancer mortality is about 30%. So you see that even at 1 sievert, which is of course a very high dose, because we are only exposed in the millisievert region, the probability only increased 5%. With the caveats that I told you. This is a little bit the summary slides. I will not read it. I mean, it's I think it's clear by now. And instead, I want to go to the non-cancer mortality. You see, these are now the data from Hiroshima and Nagasaki, from LSS14-2, for different disease. You see, stroke, heart disease, so these are circulatory disease, including stroke and infarct, respiratory disease, digestive disease, while for infectious and other, the trend is not clear. But you see that we can have radiation risks, late radiation. These are very late effects that go far beyond the cancer. And in particular, one that for sure is giving a very, very high attention is the excess relative risk for heart disease. So for cardiovascular events, stroke, infarct, severe cardiovascular events. The reason is that if you look at the dose response curve, this is excess relative from Hiroshima and Nagasaki as function of the dose. it's clear, you see, that if you go to high doses, let's say doses higher than 0.5 or 1 sievert, there is a clear increase in the excess relative risk. This is a zoom at low dose, where you see that here in this region below 0.5 is very difficult to know whether this is statistically significant or not, because it is a very large scatter. But for space, for example, this is very important because, you know, the dose in the ISS is here, but the dose for a Mars mission is about here, which means that the risk of cardiovascular disease is very high. And now, if you look at the excess relative risk, you can say, well, but this is a relatively low excess relative risk. True, but the background mortality for cardiovascular disease is even higher than cancer. It's about, in Germany, it's about 50%. So you have a 50% background mortality for cardiovascular disease and 30% for cancer. So you have to multiply this excess relative risk for a very, very high background mortality, and then you get a very, very high excess lifetime risk. You remember, let me go back for a second to this slide that show you how to calculate. You see, this is the let's take, for example, colon cancer. You see for females is 1% per sievert. If you multiply for a background of 1.1%, you get a lifetime excess risk per sievert of 1.2 per sievert. So this means that if you get 1 sievert of radiation, your probability of dying of colon cancer lifetime increase over the background of 1.2%. And so on and so forth. You see, this is at the end, if you take the total sum, is some 10% for male and 14% for women, acute exposure. So for cardiovascular events, this low, relatively low, because you see, in this case, I mean, going back here, if you take 0.2 in this table, like, I don't know, for example, pancreas for male is 0.22, but the background is for heart disease is not 1%. Then, of course, it comes with a lifetime excess risk of 0.2. But the background here will be 50%. So you see that the lifetime percent excess risk will be something like 5 times 50% times 0.2, so it's some 20%. Very, very, very high. Now, if we go to the here, so we know that we also know from non-Hiroshima and Nagasaki data, also from mostly radiotherapy data, we know that radiation is a risk factor for cardiovascular disease, you know, including ischemic stroke, stenosis and reduced blood flow, intima media thickness, and of course, stroke, you know, as I say, and the infarct. The problem again is, what is the dose response curve? In this review, we try to compare the data from Hiroshima and Nagasaki, that are the data in blue, with other cohorts, the red data, radiotherapy data. So they go to much, much higher dose. And the orange points are Mayak. This is another cohort, is the Mayak workers cohort in Russia. You see, the data are not incompatible. They pretty much, even though the exposure conditions are very different, they are pretty much in the same range. And you see that they are not, let's say, not incompatible with the linear behavior at low dose. But we have no firm evidence. This is is compatible with the linear behavior at low dose and then a saturation at high dose, but it's still unclear. And this is clearly something that we need to clarify. But it's not easy, because the mechanism, unlike the mechanisms, this should be clear to understand. One thing is cell killing. Another thing is a complex event like like cardiovascular disease. You see that the models to explain how you go from radiation to stroke, other vascular disease, or congestive heart failure here. It's quite complicated. You can have different targets even. One target is the vasculature, so the blood vessels. One target can be the heart itself. Of course, cell death plays a role both in this pattern and in this pattern. You see, cell death plays a role, but many other factors can play a role. Senescence, you know, cellular senescence, which is a pathway of cell death, but a specific one. Pro-inflammatory response, which is, you know, the release of cytokines or prostaglandins. Oxidative stress, we discussed this many times, but you can increase the overall level of oxidative stress in the cells, you see, leading to endothelial dysfunction, which again is related to increased microvascular permeability. And then you reach like arteriosclerosis or stroke and other vascular disease. And here, instead, with damage to the heart. So all these things have to be clarified to understand the real risk of radiation in inducing heart disease. Neurodegeneration is also an interesting story because neurodegeneration, the brain, we have seen it in the first plots about deterministic effects. The brain is considered a very radioresistant organ. However, there are new data, especially related to space travel, showing that if you have high LT radiation, you can have cognitive deficits. So you become stupid if you are exposed to heavy ions in space. This, of course, caused a great fuss in the community. It's interesting, you see, this is actually a review of data on neurogenesis post-radiation exposure. So these are generally data obtained in small mice, where you have a lot of generation of new neurons. Now, if you irradiate with different doses, the proportion remaining of neurogenesis decrease, but these are very high doses, though, and you see that the red is gamma rays, the black is X-rays, the high LT radiation is here. This is iron, ions are here. You see these are neutrons. So there is a strong RBE for neurogenesis. This is pretty clear. You see that there is a pool of different results showing that there is a quite clear increased RBE for the inhibition of neurogenesis. And this is somehow reflected in cognitive effects. This is a famous paper that came out 5 years ago from the University of California at Irvine. This is the discrimination index. It's a task which the mouse is supposed to learn to discriminate between two objects. This is a spherical object, this is a square object. So the animal learns which is spherical and which is squared, and it prefers to stay here rather than here. Now, if you irradiate, you see that zero gray, you see that there is a 40% of animals able to discriminate. But then if you increase the dose, you see that this discrimination index decreases and becomes even negative. So they discriminate in the opposite. With relatively low dose, you see only 5 centigrade or 30 centigrade of very heavy ions like titanium. This is with oxygen. So low dose in the order of centigrade induce a strong cognitive effect. One criticism, of course, to this experiment was a typical criticism is that this is done in acute exposure, not in low dose rate exposure. It's very difficult to do low dose rate exposure at accelerator. So the authors went to, a few years later, this is in 2019 paper, went to a neutron facility where you can have exposure at 1 milligray per day. And again, they found a significant effect. You see, the total dose, the exposure was 6 months, so the total dose was 18 gray. And this is the difference, 18 gray minus 0 centigrade. You see, this is for social interaction, avoidance behavior, time spent interacting. You see, this is a reduction, and this is an increase of avoidance behavior among mice. So they don't interact anymore. novel object recognition, you have a deficit, the famous discrimination index that we have seen previously. And object in place, the recognition is the discrimination index, but tells you where is the object, is also decreased. So even this low dose and low dose rate, now we are essentially in the same region of the mission to Mars, it actually seems to increase a significant effect. As you can imagine, this is a big story, but one problem, this is why I like this paper, because it tells you, I mean, how you have to be careful. It's a collection of all the data published on CNS effects. Orange is mice and green is rats. You see, most of the data are here. This is the age of the animals, is in this region here. But if you transform, let's say, the age of the mice in human age, you have to correct it with generally mice have a limited lifespan, not only 10, 15 years, and rats a little bit longer. So you see that the astronaut's age correlates, is about here for mice and about here for rats. So if you take the adults, there are almost very few data, if any, because most of the experiments are done with animals that are so young that the corresponding human age will be only children, only pediatric patients. So we have to be very careful in extrapolating from mouse to humans, both for the age, of course, but also for the complexity of the brain. I mean, the ideal experiment here would be to do it in non-human primates, for example. Okay, so this is for the somatic effects. Now, in the final part, I want to spend a few words on hereditary effects of radiation, because, of course, hereditary effects of radiation are probably those that you easily connect to the radiation effects. You think that if you ask, let's say, my grandmother, she's dead, but if you were able to ask them years ago, she would always say that radiation means that you have children with 3 heads. Hereditary effect, not somatic, hereditary effects. Is this true? Well, actually, of course, where do we know if it is true or not? We go to the A-bomb survivors. And the children of the survivors of the A-bomb have been studied very carefully, as you can imagine, for the untoward pregnancy outcomes, death of live-born children, sex chromosome abnormalities, electrophoretic variants of blood proteins, you know, all kinds of tests, but generally speaking, no statistically significant effects have ever been observed in Hiroshima and Nagasaki. 0, no hereditary effects. This is one of the last papers, it's 2015, so it's relatively recent, and this is the risk of death among children of atomic bomb survivors after 62 years of follow-up, a cohort study in general, and the risk of death on these children, and there is no effect. You see, these are all subjects, these are father exposure status 0 dose or higher dose. If you put all of them together, there is no difference between the 2 cohorts in terms of mortality of the children. So no hereditary effects have ever been identified in Hiroshima and Nagasaki. Why is that? Do we believe it or not? Well, the problem is that if you do the experiment on mice, so if you irradiate the father and then you mate the father with the female mouse, you see hereditary effects in the offspring. You clearly see them, but you never see in humans. We can discuss this why. Maybe if you have some ideas, will be interesting to discuss it. But eventually, SERP decided to apply a factor based on animal experiments. So this is not based on epidemiology. It's one of the few factors used in radiation protection, which is not coming from epidemiology, but is coming from animal experiments. And the total factor is about 0.6% per sievert. So this is as I told you, is about 1/10 of the somatic effects based on the animal experiment, and applies to different kind of diseases. You see, and This would be the expected excess case in 1 million live births per gray for different cases like autosomal dominant and X-linked, autosomal recessive, chromosomal, which is in many cases in the others. Chronic multifactorial, you see the background here of chronic multifactorials is huge. And this is quite clear because, you know, the chronic multifactorial include all kind of disease that are kind of transmissible, but not, but they are multifactorial. For example, diabetes, let's say, is a chronic multifactorial because it's a genetic component, but it's not 100% genetic. Same for cancer itself, you know, is chronic multifactorial. So it's a very high fraction, but you see the excess is expected to be low, and that's the total at the end. The total will be some 3,000, 4,700 cases per million birth out of 738,000 in the natural incidence. Finally, the very last case, as I told you from the beginning, is the teratogenesis. We have already seen it from the point of view of deterministic effects, but growth retardation, embryonic, neonatal, or fetal death, congenital malformation and functional impairment such as mental retardation, they are also included in the stochastic effects. We know, we have seen it already, that strictly depends on the stage of gestation at the time of exposure, especially, but this has been seen very severely in Hiroshima and Nagasaki. The microcephaly, this is a picture from Hiroshima, microcephaly was relatively common, unfortunately, among the women that were exposed in utero in Hiroshima and Nagasaki, to the point that it could be built, a dose response curve for the mental retardation when the exposure is between 8 and 15 weeks gestation. So that's the critical points, let's say, between 3 months and 4 months. That's the most, and 5 months, let's say. This is the most critical period. And this is the dose response curve, where you see you actually go down. We have seen this already. You go down to, this is in rads. So 50 rads means 0.5 gray. So this is 500 millisievert, but you clearly go down to a few millisievert, where you still have significant evidence. And in fact, you see for severe mental retardation, ICRP recommends 40% per sievert as factor, which is again approximately a factor of 10 higher than the somatic effects. And this concludes the lecture for today. We will discuss it next time, and then we will go to the radiotherapy. We will now go to the radiotherapy lecture next time. Thank you very much.